Good evening to everybody. My name is Dr. Rohit Satoskar. I'm the chair of the American Liver Foundation's Greater DC Medical Advisory Council, and I'm excited to be here tonight, and I'm excited to have all of you with us. As part of the ALF Mid-Atlantic region, we're thrilled to present our second Greater DC academic debates. We did our inaugural event last year, and it was a great success, and therefore we're doing it again. We have a little bit of a different format this year, considering the circumstances we're in, and our debate is going to be fully virtual, as you know. Some of you are joining us on YouTube. I think most of you are. I just popped over there on another screen, and I was excited to see that the chat box is already filling up there on YouTube with people cheering on their teams. So keep it up and cheer on your teams. The ALF staff have done a tremendous job in putting this together. I'd really like to thank them, and I'd like to thank all of our mentors, our fellows, and judges. Before we move on to introducing the moderator for the evening, I'd like to say a few words about the American Liver Foundation. I've been involved with the American Liver Foundation for probably close to 20 years now. And it's been a wonderful ride with the ALF. They provide really quite an important service to our patients. Their mission is to promote education, advocacy, support services for the research for the prevention, treatment, and cure of liver diseases. Across the country, ALF serves patients, caregivers, healthcare professionals through their four pillars: advocacy, research, support, and education. As a result of the ongoing pandemic, ALF's foundation, or the American Liver Foundation, has been conducting their important work virtually, and will continue to do this until it's safe to get back into the community and do some of our events where we can get together in person. Throughout this evening, we'll share some information with you about the American Liver Foundation and how they're furthering their mission and working towards a world without liver disease and how you can help. Without further ado, I'm pleased to introduce our moderator for the evening, Dr. Donald Jensen. Don Jensen comes to us from the Department of Internal Medicine, Division of Digestive Diseases and Nutrition at Rush Medical College in Chicago, Illinois. Don was our moderator last year and did a tremendous job, and so I had to invite him back again to do it this year also. I have a personal connection to Don in that I've known him also for about almost 20 years now. Don has been a mentor for me for 2 decades. He was the head of the Transplant Hepatology Fellowship Program when I was at University of Chicago as a fellow, when I participated in the academic debates back in either 2005 or 2006. So this event is very near and dear to me. So I'd like to turn it over to Dr. Jensen.
Thank you very much. Thank you. Thank you very much, Dr. Satoskar. Let me see if I can get my... Hopefully, I should be...
We can hear and see you fine, Dr. Jensen.
Okay, I can't see me, so that's okay. So thank you, Dr. Satoskar, for that introduction, and good evening, everyone. I am proud to be a part of the American Liver Foundation's second annual academic debates for Greater DC. While last year we had an incredible inaugural in-person event, this year's obvious situation has forced us to turn into a virtual event. I would like to take a moment to share with you what this evening will look like. As was mentioned, we will host 3 debates tonight. The questions posed to these fellows are ethical in nature with no right or wrong answer. Through these debates, we seek to stimulate higher thinking about significant issues which impact the liver of people living with liver disease. And debaters will be judged on their presentations, the research done to support their arguments, and their ability to respond quickly to the opposite viewpoint. We hope this evening stimulates greater passion and enthusiasm for the field of hepatology, ultimately leading to improved care for liver patients. The debates will be fast-paced. We will start each debate with a pro presentation, followed by the opposing con presentation. Each side is allotted precisely 8 minutes to present their argument. Should someone exceed their 8 minutes, our diligent timekeeper will disconnect their audio and visual. So be on time. We will do our best to transition smoothly from one presenter to the next to keep our program flowing. Once both arguments have been presented, each side will have the opportunity to challenge their opposition with a 5-minute rebuttal. Again, this will be closely timed. We will have a question and answer session following the rebuttals. Again, this will be closely timed. If time permits, following the judges' questions, we will bring your questions forward to the people who are rebutting the presentations. After each debate, I will enter a judging session with our distinguished judges, and at the conclusion of all 3 debates, we will announce our winners. Next slide. Dr. Satoskar indicated tonight we are also asking for your help to support the American Liver Foundation. We do not yet know when it will be safe to host traditional in-person fundraising events. While the ALF has creatively developed exciting virtual fundraising events, which we will share with you later this evening, but now more than ever, your dollars mean more. As we all know, many liver patients are uniquely vulnerable to COVID-19 and rely upon the ALF for essential information, support, and guidance. Tonight, please help us reach our fundraising goal by donating. You can follow the link provided in the chat box. We would like to take a moment to acknowledge the incredible above and beyond work of every healthcare professional. I don't think anyone could have imagined what would unfold in 2020, but it is no surprise to see the dedication, selflessness, and commitment all of you have made and displayed this year. Thank you for your sacrifices and your efforts. Please continue to stay safe. We salute you. I would like to take a moment to acknowledge the incredible above and beyond work of every healthcare professional. I don't think anyone could have imagined what would unfold in 2020, but it is no surprise to see the dedication, selflessness, and commitment all of you have displayed this year. Thank you for your sacrifices and your efforts. Please continue to stay safe. We salute you. I would like to take a moment to thank our generous sponsors. In Greater DC and throughout the country, we appreciate your support for all we do. Locally, we are grateful to AbbVie and Bayer for their support. This year, we have also received national support for our academic debates from our National Expo sponsor, Mallinckrodt, the National Bronze sponsor, CVS, and of course, our National Gold sponsors, Salix and ASE. We will now play a brief video from ASE. Please note this video does not contain sound. Following that, we will play a brief video from Salix. Thank you.
high-quality Right now, millions of patients are suffering with GI disorders such as overt hepatic encephalopathy, irritable bowel syndrome, chronic idiopathic constipation, opioid-induced constipation, bowel preparation, and ulcerative colitis. At Salix, we have kept up with these unmet needs for more than 30 years by providing an industry-leading portfolio of high-quality products that address these conditions. Through our dedicated and innovative R&D team, we're also exploring potential new scientific breakthroughs. And we remain committed to important healthcare provider investments in education, charitable grants, and sponsorships. We will continue to invest millions of dollars in patient education and do our best to broaden access to Salix medications. Because our mission to improve the care for GI patients continues today. For us, there is no finish line.
Thank you, and please join me in welcoming the judges for this evening. Debate number 1 will be judged by Dr. Rohit Satoskar from MedStar Georgetown University Hospital and Dr. Tinzeh Wareda from Johns Hopkins University School of Medicine. Debate number 2 will be judged by Dr. Curtis Argo from the University of Virginia and Dr. Frank Anania from the U.S. Food and Drug Administration. Debate 3 will be judged by Dr. Kirti Shetty from the University of Maryland and Dr. Arul Thomas from MedStar Georgetown University Hospital. As a moderator, I will serve as the tiebreaker for each debate if necessary. So the first debate, and with that, let's start our first debate. The first debate poses the question, should a patient with type 2 diabetes and advanced NASH fibrosis with a BMI greater than 35 undergo treatment with bariatric surgery as a primary treatment for NASH? Debating the pro position is Walter Reed National Military Medical Center. Walter Reed will argue that a patient with type 2 diabetes and advanced NASH fibrosis with a BMI over 35 should undergo treatment with bariatric surgery as a primary treatment for NASH. The fellows presenting for Walter Reed are Dr. Sarah Ordway and Dr. Christina Steinhauser. The mentor is Dr. Dawn, sorry, my screen just went a little nuts. And I don't know how to get us back. The con position will be by the University of Virginia, and they will argue that a patient with type 2 diabetes and NASH fibrosis with a BMI over 35 should not undergo treatment with bariatric surgery for NASH. The fellows representing the University of Virginia are Dr. Laura Carlini and Dr. Miller. Their mentor is Dr. Curtis Argo. As a reminder, each position presentation will be allotted precisely 8 minutes and rebuttal will be allotted precisely 5 minutes. Timekeeper, are you ready? Let's begin.
Good evening. My name is Sarah Ordway, and my co-fellow Christina Steinhauser and I will be presenting the pro side for bariatric surgery as the primary treatment for a patient with morbid obesity, type 2 diabetes, and NASH with advanced fibrosis. This is our standard disclaimer. Non-alcoholic fatty liver disease has become one of the most common chronic liver diseases in the world, affecting up to 1/3 of the general population in Western countries and costing the US healthcare system $32 billion annually. NAFLD is characterized by hepatic steatosis that can progress to non-alcoholic steatohepatitis, NASH. In the US, NASH is a growing cause of cirrhosis and hepatocellular carcinoma. NASH cirrhosis has become the second most common indication for liver transplant waitlisting and is becoming a leading indication for liver transplant. With trends in obesity and the metabolic syndrome, these numbers are expected to rise across the globe. CDC data from the US shows a startling trend. In 2011, 11 states reported the lowest obesity rate between 20 to 25%. In less than a decade, only 2 states, DC and Colorado, have an obesity rate of 20 to 25%, while a dozen states have reached the topmost category of over 35%. NAFLD is closely related to obesity and type 2 diabetes, often termed the hepatic manifestation of metabolic syndrome. In a study of the UNOS database, including 57,000 liver transplants performed between 2003 and 2012, the presence of diabetes at the time of transplant was found to be an independent predictive factor for worse transplant survival. Diabetes was identified as a predictor of poor waitlist outcome, and cardiovascular causes of death were more common in diabetes patients compared to non-diabetes patients. We know that fibrosis is the most reliable predictor of liver-related mortality. As you can see in the study of over 600 patients with fatty liver disease, patients with fibrosis had worse survival with median follow-up of 12 years. The most common causes of mortality were cardiovascular disease and malignancy. Sustained weight loss through lifestyle changes, including diet and physical activity, is often the first step of therapeutic management. However, weight loss of at least 7 to 10% of patients' body weight is necessary for regression of NASH, and only 10% of patients reach this objective with lifestyle therapy at 1 year. And of those, fewer than half maintain the weight loss 5 years later. This amount of weight loss is notoriously difficult to maintain, as demonstrated by most contestants on the popular show, The Biggest Loser. And while there are several other pharmacologic treatments under investigation, none have been proven to be effective in treating NASH thus far. Bariatric surgery is superior in maintaining calorie restriction and long-term weight loss, with reductions in hepatic fat, inflammation, and most importantly, fibrosis. Roux-en-Y gastric bypass surgery is the most effective treatment for obesity and glycemic control in patients like ours with diabetes. And sleeve gastrectomy is an alternative approach that significantly reduces gastric volume without changing upper GI tract anatomy with comparable outcomes. Fibrosis is key. Histology massively improves with bariatric surgery. In this study just last year, evaluating whether morbidly obese patients with advanced NASH, meaning stage 3 or 4 fibrosis, improved after bariatric surgery. Follow-up liver biopsy was performed about 6 years after surgery, and as you can see, histology massively improved in the majority of patients. Patients who had gastric bypass were 80% more likely to have resolution of severe fibrosis at follow-up. And just this summer, in a prospective study of 180 severely obese patients with biopsy-proven NASH, displayed on the chart on the left, NASH resolved in liver biopsies in 84% of patients 5 years after bariatric surgery. And more weight loss led to higher resolution. As shown on the right, 70% of patients had fibrosis regression. You can see that the reduction of fibrosis began during the first year and continued through 5 years. That is impressive. Effects of bariatric surgery go beyond NASH though, inducing long-term weight loss and remission of diabetes in 76% of patients. Most importantly, it also reduces long-term mortality, cardiovascular events, and cancer. Our opponents will tell you that bariatric surgery comes with too high a risk of complications in patients with advanced fibrosis. However, a 2018 nationwide analysis found no increased risks of postoperative complications or cirrhosis-related complications in patients with cirrhosis undergoing bariatric surgery with a follow-up of 18 months. And there's actually an association between prior bariatric surgery with decreased mortality in morbidly obese patients. Some earlier studies were concerning for small subsets of patients who had increased fibrosis after bariatric surgery. However, a recent meta-analysis revealed that the largest study, including more than 500 patients, there were no cases of worsening fibrosis 5 years later. In conclusion, obesity is a public health crisis. Bariatric surgery is more effective than lifestyle modification at achieving sustained weight loss, which only 5% of patients are able to do. It induces remission of metabolic syndrome and fibrosis and NASH, negating the need for transplant, and has been shown to be safe in patients with advanced fibrosis. But most importantly, it reduces their overall mortality. These are our references. Thank you so much for having us tonight.
Thank you. Thank you, Dr. Ordway. And at this time, I'd like to ask the Khan presentation by Dr. Lauren Carlini to take over. Thank you.
First of all, thank you to the American Liver Foundation for inviting us to participate in this debate. We will now be arguing the Khan position. The prevalence of NAFLD is estimated to be 20 to 40% in the general Western population, and NASH cirrhosis is on track to become the leading indication for liver transplant in the US. If bariatric surgery could help curtail this rise in NASH cirrhosis, it's clear to see how this could be very beneficial. However, as we'll demonstrate, the evidence is not currently robust enough to support bariatric surgery as a primary treatment for NASH, especially in patients with advanced fibrosis. A very telling point about the quality of data regarding bariatric surgery's impact is that there have been no randomized controlled trials comparing outcomes after bariatric surgery to outcomes with either standard of care or no interventions in NASH patients. In looking at the natural history of NAFLD, a study analyzing 103 patients with multiple liver biopsies demonstrated that fibrosis worsened in 37%, was stable in 34%, and improved in 29% of patients at a mean of 3.2 years between biopsies. Due to the dynamic natural history of NAFLD and the fact that fibrosis is commonly misstaged, without randomized controlled trials, it's difficult to know if regression in fibrosis after bariatric surgery is indeed superior to patients receiving the standard of care or no interventions at all. On top of this, the studies that have been done have demonstrated a subset of patients have worsened fibrosis after surgery. Additionally, few patients with advanced fibrosis have actually been included in these studies. In an important study by Matherin et al., NASH patients who underwent bariatric surgery had liver biopsies at surgery with repeat biopsies at 1 and 5 years post-op. Steatosis, ballooning, and NAFLD activity score decreased over this time period. Inflammation overall did not change significantly. However, levels of fibrosis increased significantly over the same time period. I've outlined in orange the patients that had worsening of fibrosis at year 1 compared to baseline. More than 20% of patients with no fibrosis at baseline had fibrosis at 1 year. 9% of patients with stage 1 fibrosis at baseline had progression, as did 33% of patients with stage 2 fibrosis at baseline. There were only 2 patients with advanced fibrosis, that is stage 3 fibrosis in this case, at baseline that had repeat biopsies 1 year after surgery, and neither had regression of fibrosis at that time. The year 5 data shows similar rates of progression and regression of fibrosis. Approximately 25% of patients with no fibrosis at baseline had fibrosis 5 years after surgery, raising the question of whether bariatric surgery significantly alters the course of fibrosis in NAFLD. Unfortunately, None of the patients with stage 3 fibrosis at baseline were biopsied 5 years after surgery. Without many patients with baseline advanced fibrosis, it's difficult to conclude that weight loss surgery should be a first-line therapy in these patients. The low number of advanced fibrosis patients is a strong indicator of substantial selection bias in this and most studies of bariatric surgery interventions in this population. The advantages of any intervention must be carefully weighed against the possible risks. As I'll demonstrate, the surgical risks in patients with compensated cirrhosis are higher than in the general bariatric population. In a study by Moscow and Nguyen, using a national database of patients who underwent bariatric surgery, the in-hospital mortality rate for patients without cirrhosis was 0.3%, compared to patients with compensated cirrhosis, 0.9%, and decompensated cirrhosis, 16.3%. The adjusted odds ratio of death after bariatric surgery, as highlighted in this table, was 2.2 in compensated cirrhosis and 21.1 in decompensated cirrhosis. In Jan et al.'s review of 9 studies with a total of 122 well-compensated cirrhotic patients that had undergone bariatric surgery, the total complication rate was 21.3%. The risk of liver decompensation was 6.55%. Risk of early mortality was 1.6%, and risk of late surgical mortality was 2.45%. When deciding if bariatric surgery should be used as a first-line treatment, we should also consider whether these procedures will affect outcomes we care most about, namely the risk of progression to cirrhosis or decompensated cirrhosis and overall survival. Weight regain after bariatric surgery is a known long-term outcome in a significant portion of patients, even leading some patients to need a repeat bariatric procedure. At this time, robust long-term data in patients with NASH and advanced fibrosis who underwent bariatric surgery is limited. How weight regain impacts on the long-term results in this subset of patients is thus unknown. Jimenez et al. Attempted to address this in their prospective observational cohort study of patients who underwent Roux-en-Y gastric bypass. They compared non-invasive NAFLD fibrosis scores in 3 different populations: those with no weight regain, expected weight regain, and excess weight regain or recidivism, which they defined as regain of greater than 20% of maximum weight loss. Of 90 total patients that were followed for 3 years after surgery, 35.6% had excess regain, 28.8% had expected regain, and 35.6% had no regain. The fibrosis score was not significantly different at baseline when comparing these groups. At 3 years after surgery, all groups had a significantly decreased NAFLD fibrosis score compared to baseline. However, patients in the excess weight regain group had a significantly higher NAFLD fibrosis score 3 years after surgery compared to the other 2 groups. Though this was a non-invasive measure of fibrosis in these patients, it at least raises the question of whether long-term benefits persist in all patients. Finally, Goossens et al. Retrospectively analyzed 492 patients who underwent bariatric surgery for a median period of 10.2 years. NASH at the time of bariatric surgery was significantly associated with higher risk of mortality compared to patients without NASH. They also compared NASH patients in the bariatric surgery cohort, labeled Geneva on this graph, with propensity score matched NASH patients in a large national health survey who did not undergo bariatric surgery, and found no difference in the overall probability of survival between the 2 groups, as seen in graph F. In comparison, graph E demonstrates that the general bariatric surgery group did have long-term survival benefit compared to the propensity score matched patients. The fact that there was no survival benefit associated with bariatric surgery in NASH patients during a long-term follow-up period certainly raises the question of whether the risks of pursuing bariatric surgery are worthwhile in this patient population. In conclusion, there are many questions that remain to be answered regarding the safety and long-term efficacy of bariatric surgery in NASH patients with advanced fibrosis, but at the current time, the data does not support this as a first-line option for treatment of this population. Thank you so much.
Thank you very much to both presenters. I think you've had great opportunities to present your case. Now we'll hear the rebuttal from the position by Dr. Christina Steinhauser from Walter Reed. Dr. Steinhauser.
Thank you for having me. My name is Dr. Christina Steinhauser. I'm going to be presenting the pro rebuttal. So our opponents will argue that weight loss with diet and exercise is achievable with less risk than bariatric surgery, but the data presents a strikingly different reality. In a system where participants are provided substantial support, weight loss is not persistent. A study published by the Journal of Obesity in 2016 examined 14 contestants from the popular weight loss competition show The Biggest Loser. At the time of their participation in the show, before and after their initial losses, and then they followed up with them 6 years later. After 6 years, most of the subjects had regained a significant portion of the weight that they had lost on the show. This highlights a reality that many of our patients face. Diet and exercise alone have a high rate of weight regain, even in those who saw initial success. Extrapolation of this data also highlights another hurdle. Replication is unrealistic. Production ran 30 weeks. Contestants were supported by a team of nutritionists to make their food, coaches to guide their exercise, and all of this existed in a bubble where they did not have the pressures of their daily life. The reality is that our patients cannot replicate these conditions and remove themselves from the pressures of their life and their job while they struggle to lose weight every day and making choices on their own. When the contestants returned to their normal routine, leaving the bubble where weight loss was their only job, the weight came back. That weight cycling led to a significantly decreased leptin, decreased basal metabolic rate that would be expected for a person of their size. 6 years after the competition more accurately reflect the real struggles our patients will face. And the reality is that the majority will not be able to keep that weight off. It's intuitive to want to support our patients to success in their own right, but the reality is that the scales are tipped in favor of bariatric surgery as the most successful avenue for reducing morbidity and mortality from NASH. Our opponents will ask you to consider the long-term outcomes and surgical risk involved with operating on a population that does carry comorbid conditions. While patients may see a modest benefit from diet and exercise, the ultimate goal is decreased inflammation and fibrosis. Without sustained weight loss, we cannot hope to achieve either of these goals that may ultimately require liver transplant. The long-term implications of transplant surgery far outstrip those of bariatric surgery, which has the ability to prevent progression and keep a native liver in place. Looking at the risks of bariatric surgery as a whole, even in higher risk subgroups, there are comparable outcomes and the complication rate is low. The longitudinal assessment of bariatric surgery was an observational cohort study that followed nearly 2,500 adults after bariatric surgery, comparing Medicare and non-Medicare subgroups. At 5 years, average weight loss was 30%, with over a third of these patients achieving diabetes remission. Even in higher risk subgroups, the observed rate of adverse events was less than 7% for Roux-en-Y and as low as 1.8 for lap-band. What about those who already have advanced fibrosis? While cirrhosis is a relative contraindication to bariatric surgery, a study published by Rubibo and colleagues showed that there was no increase in postoperative mortality or cirrhosis-related complications in patients with NASH cirrhosis who underwent sleeve gastrectomy. Our opponents may ask you to consider what our current AASLD guidelines say about the therapy for NASH. According to these guidelines, surgery is not considered first line due to the surgical risk. However, the EASL guidelines recommend consideration in selected patients. This recommendation is made when considering surgery for patients without a second metabolic condition that would be expected to improve with weight loss. We would argue that for those patients with NASH as a standalone diagnosis, there may not be enough data to make such a recommendation. But in the case of patients with concomitant diabetes, the evidence is clear. Bariatric surgery is the most effective way to achieve lasting results in a disease that is poised to become the top indication for liver transplant in the US. The treatment is ultimately a surgical one. Either we refer for bariatric surgery or we allow a disease to progress to the point where their surgical option is transplant. Bariatric surgery is the most effective tool to reverse the effects of the growing epidemic of obesity. When we recommend a treatment, it's because we believe that a patient can be successful. If only 5% of obese patients are able to see success with a treatment in any other disease process, this would be unacceptable. The ultimate goal in every case is sustained physical and emotional well-being for our patients, and we firmly believe that bariatric surgery in these patients is the way forward. Thank you.
Thank you very much, Dr. Steinhauser. And now for the rebuttal for the con position will be Dr. Jennifer Miller. Dr. Miller.
Thank you. I commend my colleagues for nicely presenting the data supporting the use of bariatric surgery in the obese patient with NASH, advanced fibrosis, and diabetes, but I will argue that the points you have heard are not strong enough for us to recommend bariatric surgery in this patient population in the year 2020 as first-line therapy. The first point that I will stress is that while bariatric surgery can be a powerful weight loss intervention, it is inappropriate to use as first-line therapy due to its lack of long-term strong evidence. The American Association Study for Liver Disease states that lifestyle modifications are first-line interventions and that in the absence of randomized controlled trials, caution should be used when interpreting the effects of bariatric surgery on this patient population. I will also point out that EASL guidelines recommend surgery consideration after conservative measures are attempted. And next, the television show, The Biggest Loser, is not a randomized controlled trial. A meta-analysis in 2019 observed 32 studies that are evaluating the effects of bariatric surgery in the NAFLD population. Unfortunately, none of these are randomized controlled trials. The majority of these studies are small, with an average N of 105 patients and a median follow-up of 15 months. Furthermore, it is important to recognize that most of these studies are single-arm studies looking at the effect of bariatric surgery in the NAFLD patient after surgery, not comparing them to any conservative groups. Selection bias is a significant inherent weakness of these studies. They generally present no rationale for why patients were selected for surgery or not. Therefore, we posit that these studies likely represent the best case scenario for our patients with NASH. Next, we address the point that bariatric surgery will result in weight loss with concomitant histologic improvement, as well as fibrosis regression. I will argue that this outcome is far from guaranteed. Unfortunately, aside from fibrosis on index liver biopsy, predictive variables for which patients with NAFLD will progress to severe liver disease are still unclear despite 20 years of intense clinical investigations. Likewise, predictors of which patients will derive long-term benefit from bariatric surgery also are lacking. In a meta-analysis from 2015, at least 12% of patients with NASH who underwent bariatric surgery developed de novo biopsy-proven fibrosis. Furthermore, the other histological outcomes that you have seen are variable. Therefore, we recommend that application of randomized controlled trials as well as gene level analysis be used as predictors for the patients most likely to achieve benefit from bariatric surgery, rather than using bariatric surgery as first-line treatment for all patients when we are unclear of who will benefit or not. Sustaining weight loss long-term after bariatric surgery is another question we raise. At least 41% of patients will regain weight starting about 2 years after bariatric surgery. Predictors associated with regain are unclear. Those people who regain weight will potentially be recommended for revisional surgery. Revisional surgery is one of the fastest growing categories in bariatric procedures, and unfortunately, its efficacy, outcome, and safety are unclear as well. There have been reports of up to a complication rate of 41% in these procedures. This speaks to the quick fix nature of bariatric surgery and the lack of high quality long-term follow-up data in this surgical procedure. It also calls into question the motivation of surgeons to uncover true long-term efficacy of this profitable procedure. Next point to address is the idea that all bariatric surgery is safe. Excellent weight loss and improvement in comorbidities certainly comes at a cost with bariatric surgery. A 2015 meta-analysis showed that Roux-en-Y gastric bypass in the NASH patient is associated with a 31.3% risk of complication and a 3.9% risk of mortality. Furthermore, NASH patients undergoing sleeve gastrectomy have a complication rate of 14.6 and a risk of hepatic decompensation of 12.5%. These rates of complication are certainly higher than we are willing to accept for these patients. An interesting point to elucidate is the surgeon's perspective on operating on patients with advanced fibrosis. In a previous study, up to 27% of surgeons said that they would not perform procedures in these patients. My final points. Surgery may be a potential powerful tool to induce weight loss, but the risk-benefit analysis of help versus harm does not have tangible, convincing evidence, rather a modest collection of small studies with inherent selection bias. We feel we have convincingly shown that using bariatric surgery to treat obese NASH patients with advanced fibrosis should not be used as first-line therapy at this time due to the underreported risks, unclear trajectory of benefit, and overall lack of long-term outcomes or randomized controlled trials at this time. Thank you.
Thank you, Dr. Miller. And thank you to all four of our amazing speakers. And at this time, we have a few minutes for some questions from the judges. And let me start with a couple of questions. So a question really for Dr. Steinhauser. So if there is, I mean, you've proposed that the risk of fibrosis progression is really negligible in patients who have bariatric surgery, but yet some of the studies do demonstrate that there is some potential for fibrosis progression in a small group. Some patients may even have acute liver failure as a complication of bariatric surgery, although that's very rare. So how would you monitor a patient who's had bariatric surgery for those complications? And then what would you do if you did find evidence of progression of their fibrosis?
So looking at the studies that did have a subset of patients with worsening fibrosis, there is some early data. It was a little too early to extrapolate out about some genetic predispositions. And then there's a subset of patients that did show a slight worsening of fibrosis, but didn't increase their overall fibrosis score. It didn't bring them from F1 to F2 disease. And then looking at a more recent meta-analysis that included all of those studies, it really did show no statistical significance, and that was extrapolated out since it really did just pull in a bunch of studies that were much smaller that showed that subset. And I think if we are able to move forward, we could pre-screen our patients a little bit, and we may be able to mitigate it with patient selection for finding the ones that may not benefit from bariatric surgery, because again, that is probably a very small subset that was evidenced by the older studies, but in the more recent meta-analysis, we're finding that that group is smaller and smaller.
Thank you. Thank you. And Dr. Miller, I have a question for you. We've shown the data suggests that certainly bariatric surgery is effective. It may be risky, but it certainly suggests that its efficacy is there. So what alternatives do you propose for patients with the same profile, advanced NASH, diabetes, and obesity, if you're not going to use bariatric surgery? What are your options?
Sure, thank you for the question. I'd like to first clarify that I agree that bariatric surgery can result in significant weight loss, but I think that due to its unclear risks and lack of randomized controlled trials, the idea of using bariatric surgery as first-line therapy in these patients is not appropriate. I do think that, like my opposing team commented on, we don't have the resources in place to sustain lifestyle interventions. However, I do think as a healthcare community, it's important for us to emphasize these things in clinic, learn about them better as physicians, and help our patients to be more successful in those ways, rather than a quick fix surgery that we have unclear outcome data on.
Thank you very much. And now I'd like to ask our judges if they have questions. And let me start with Dr. Satoskar. Dr. Satoskar, do you have any questions for the presenters?
Yes, thank you. So tremendous presentations by both groups. So congratulations. This is going to be a hard one to judge. You guys both really did an excellent job. So I have a question for Dr. Ordway. So in patients, so we talked a lot about risk and the surgical risk for these patients that have advanced fibrosis. How would you approach a patient in terms of risk stratifying them for bariatric surgery? And when is it too late to recommend bariatric surgery?
Thank you, Dr. Satoskar. That's a really good question. I think it's really important to start having these conversations early with patients. I think a lot of times we forget to bring up bariatric surgery as an option for patients who have been struggling with weight loss for years. And I think it's really important to bring up right away with patients whether or not they have advanced fibrosis. There are calculators to help assess risk for any surgery for patients that I'll often use to see what the risk of surgery would be. But I think just giving them the option to undergo bariatric surgery early is very important. It's important to remember that bariatric surgery goes hand in hand with lifestyle modification. This isn't a quick fix surgery that we're offering. Patients are required to commit to lifestyle changes as well. So this is not something that they take lightly. And I think just introducing the conversation early is really important. I'm sorry, you asked a follow-up question and I don't remember.
I just asked a little bit about risk stratification too. Sort of, is there a point where it's too late for someone to undergo bariatric surgery where you'd say that, you would not recommend it because there's too much disease or too advanced disease?
I think that's really important. So if someone has decompensated cirrhosis, I would be very hesitant to recommend bariatric surgery. Their mortality is already very high, and I think this population probably wouldn't benefit very much from a surgery.
Thank you.
Dr. Warita, do you have questions?
Tinsy, I think you're still muted there.
Oh, sorry about that. So yes, I do have one question. And so thank you to both teams for your wonderful dynamic presentations. Like Dr. Satoskar said, it's going to be very difficult to judge. You did a phenomenal job. My one question was to the UVA team. One of the main points that you focused on was the lack of randomized controlled trials to support bariatric surgery in the treatment of patients with NASH, including patients with advanced fibrosis. So I wanted to ask you, based on your review of the studies, why do you think there has never been a randomized trial? And do you think that there will be any in the future?
Let me try to take it. Okay. Thank you for the question. I think, just like you, I thought the same things. And while I was going through the data, I think randomized controlled trials take a lot of resources. And I feel I understand that some do not believe that bariatric surgery is a quick fix surgery, but in my mind it is. And I think that we are, as a culture, more excited about quick fixes than hard work and dedication towards weight loss, because we can all attest to the fact that it's not easy with lifestyle modifications. However, I would argue that the risks are unclear given the lack of randomized controlled trials. And so it's to be determined if we could actually support the use of bariatric surgery as first-line therapy.
And so we have a question from one of our other judges for a later program, a later part of this program. Dr. Ananaya, do you have a question for one of the presenters?
Yes, congratulations, a great set of talks. I enjoyed them. I have a question for Dr. Carlini from UVA. You presented data about mortality in compensated cirrhotics, so by definition they're all F4s. Did you find any data about the F2 and F3 patients in terms of their mortality in bariatric surgery?
Yeah, that's a great question. I really didn't find any data comparing the mortality rates in that stage of patients, and I'm not sure exactly the reason. It could be that they don't have biopsy proven fibrosis at the time, or there isn't a large enough population, but I couldn't find any data specifically talking about the risk of mortality in that population of patients. So,
thank you very much.
Okay, that was great. And I think at this time, I will now join the judges in a private breakout room while they review their notes and determine the winner for this first debate. In the meantime, I would like to pass you over to Lindsay Ventura from the American Liver Foundation to share information about how the ALF is continuing to fill the needs and engage the community of liver patients in our country. Lindsay.
Thank you so much, Dr. Jensen. So as Dr. Jensen said, he is now going into a breakout room to help the judges deliberate and make their decision. I truly don't envy them a bit. While they work to make their hard decision, I'd like to tell you how you can continue to support our work and engage with us in all of our different virtual events. I'd like to really start by personally thanking our sponsors who have helped to make this evening a success. Your support is invaluable to us and truly allows us to continue supporting our patient community. We're thankful to our local sponsors for this debate, AbbVie and Bayer, and of course, we're grateful to our national academic debate sponsors. Our national expo sponsor is Mallinckrodt, our national bronze sponsor is CBS, our national gold sponsor is Salix and ASI. Thank you so much for your support. I'm just having some trouble progressing my slide. It's always the easiest things. So as we've discussed this year, we are reimagining our events and our programming into these virtual things. Every year, the American Liver Foundation organizes patients and caregivers to go to Washington, D.C. and present our legislative priorities to their senators and congressmen and congresswomen. As a patient and caregiver myself, I actually had hepatitis C and my mother underwent a transplant about 6.5 years ago. I've been able to attend our annual advocacy day as a patient. It's such a powerful experience to step out of the all too common silence of liver disease, share our personal stories, and advocate for positive change. Even more powerful is to actually see shifts in the legislation as a result of our work. The American Liver Foundation, for example, intensely advocated for changing the recommendations for hepatitis C testing. To see that change actually come to fruition earlier this year, helping to reduce the stigma and increasing our chances of diagnosing people before their diseases progress to the need of transplant was truly incredible. This year, we are going virtual with our advocacy, so we're excited what a virtual advocacy event will mean for our increasing our impact, engaging more advocates. We'll be training new advocates on September 30th, and we have organized virtual visits to happen all week, the week of October 5th through 9th. While registration did close yesterday, we invite you and your colleagues and your patients to join us in email campaigns and other online advocacy. Be sure to follow us on Facebook and check out our advocacy page for more information. The link will be in the chat box. That's my email, not the next slide. The American Liver Foundation does remain dedicated to conducting essential patient education, despite our ability to meet in person. When patients are well educated about their conditions, they are more likely to play an active role in their care team while reducing fear and anxiety of the unknown. Please help us spread the word about our liver cancer conference to your patients and your local communities. This conference will take place over the course of 2 days, October 16th and October 17th. The program is designed for people with liver cancer for whom transplant is not an option. As you well know, liver cancer rates continue to rise throughout our country, and options are very limited. Many patients are diagnosed when they're already outside the Milan criteria or may have another condition which excludes them from transplant. Liver cancer is devastating for patients and families, particularly those without the hope for a curative transplant. Please inform your patients and community about our liver cancer conference this October. You will find the link in the chat box, which we do urge you to share. Thank you to those who joined us virtually for our annual Mid-Atlantic Liver Life Walk. We know that while many patients were able to represent our hospital teams, many healthcare professionals were unable to attend in the spring as a result of the pandemic. Whether you missed it in the spring or you just want to do something a little bit different, we hope you will join us for the new fall virtual Liver Life Walk. Every week, we'll focus on something different. Last week, we had a focus of self-care. We offered medications, self-care meditation, self-care bingo, and even a little live restorative yoga session. In the coming weeks, themes will include movement, exercise, cooking and crafts, and of course, liver education. Registration is now open. I personally joined Team ALF. I linked my Fitbit to my walk page, and I'd really love to see my steps add up. Our walk is a great way to not only generate essential funds, but to increase awareness for all ALF. I'd like to also share with you information about our virtual culinary event. I'm sure many of you have attended our Flavors event. I was lucky enough to attend Flavors of Philadelphia event last year with my mom. It happened to fall on her 5-year liver transplant anniversary, and it was such a great experience. While we can't serve up our incredible food at the Flavors events this year, we're excited to host our first ever virtual culinary event. This virtual experience will happen on November 21st. It'll offer unique local and national engagement opportunities for the liver community, and it's really sure to excite the foodie in all of us. We'll be bringing 2 seasoned top chefs into your kitchen, and we'll have a fun and interactive cook-along. You'll follow step-by-step instructions from our top chefs and prepare a HelloFresh signature dish alongside them. Please follow the link in the chat box to learn more and to register. And truly, I just wanted to provide one last note. Despite the drastic and dramatic sudden shift from in-person events and programs to total remote work where we find ourselves, there is still a lot going on at the American Liver Foundation. Please be sure to engage with us on all of our social media platforms to find out more about what we're doing. We're on Facebook, LinkedIn, Twitter, Instagram, and of course, YouTube. While you watch this evening's debates, please actually just subscribe to our YouTube page. By following, liking, and subscribing to us on all of our social media pages, you'll be alerted to all of the exciting events and programs that we have going on. So I think actually our judges have made their decision. I'm sure it wasn't easy, but I will now turn it back over to Dr. Jensen to introduce our next academic debate.
Thank you. Thank you very much. So our second debate is, should hepatitis C positive donors routinely be considered for hepatitis C negative transplant candidates? Debating the pro position is MedStar Georgetown University Hospital, and MedStar Georgetown will argue that hepatitis C positive donors should be considered for HCV negative candidates. The fellows representing MedStar Georgetown are Dr. Talib Baba and Dr. Ghazan Al-Zayer. Their mentor is Dr. Arul Thomas. Debating the con position is the University of Maryland. The University of Maryland will argue that hepatitis C positive donors should not be considered for hepatitis C negative candidates. The fellows representing University of Maryland are Dr. Elizabeth Stonecipher and Dr. Bilal Asif. Their mentor is Dr. Kirti Shetty. As a reminder, each position presentation will be allotted precisely 8 minutes, and each rebuttal will be allotted precisely 5 minutes. Timekeepers, are you ready? And we'll start with the pro presentation. Thank you.
Thank you, Dr. Jensen, for the introduction. Thanks to the American Liver Foundation for organizing this event tonight and giving us the opportunity to take part. So, sorry, my slides are, okay, there we go. So the foundation of our argument is that our supply does not meet the demand in the liver transplant world. And in an age where we have increasing discrepancy between supply and demand for organ transplant, increasing indications for transplant due to rising incidence of NASH, as our colleagues mentioned earlier in the previous debate, as well as HCC, this has led us to use innovative ways to increase our graft pool. We should continue to explore all available options where a graft could be the difference between a life or death. According to the data from Organ Procurement and Transplant Network, there are 109,000 men, women, and children awaiting transplant for different organs, while only around 39,000, that was in 2020, as of September 2020, while only 39,000 patients were transplanted in 2019. There are 17 people dying on a daily basis awaiting an organ transplant. Now that we have great treatments for hepatitis C, this has allowed us to transplant hep C grafts in patients regardless of their hep C status. And while the number of transplanted hep C grafts has been steadily going up as we went from the interferon era into the DAA eras, there are still available organs that are not being used. As you can see on this graph that I got from the SRTR annual data report, which shows the steady increase from 2005 to 2015. However, according to the same report, there were 7.6% of the HCV grafts that were discarded in 2018. This accounts for almost 600 livers, and those are organs that we cannot afford to lose. Now, hepatitis C incidence has been on the rise in recent years, with over 50,000 cases reported in 2018, new cases basically. And they're mostly related to IV drug use. This IV drug, this opioid epidemic resulted in an increasing number of deaths secondary to drug overdose. And while this is massively tragic, it has resulted in an increased supply of hep C positive grafts. This has also resulted in a steady drop in the average age of hepatitis C positive donors, providing younger, healthier liver grafts. And as evident of this graph, as you guys can see, the average age went from 47 to 35 from 2012 to 2018. As for treatment for hep C, we have several available regimens that we can effectively treat hep C with. They have nearly 100% SVR rates post-transplant. They're all well tolerated. They're easily accessible. And adding a medication for a few weeks in the pill box would have minimal increased burden in the post-transplant phase. This is even recommended by AASLD specifically for uninfected recipients of liver grafts from HCV viremic donors. Using HCV graft is not a novel concept. Our nephrology colleagues have been successfully using hep C grafts with good outcomes. This is a study from 2019 that was published in the Journal of American Society of Nephrology, which showed comparable outcomes regardless of hepatitis C status of donors. And this is a direct quote from their study: HCV viremic kidneys are a valuable resource for transplantation. Our colleagues in cardiology and pulmonology have also found good success with excellent outcomes at 6 and 12 months. Again, looking at the SRTR data between 1995 and 2013 of HCV positive recipients of liver transplant, which accounted for over 33,000 patients. Long-term survival, which is, as you see on this graph, is up to 10 years in this case, was not affected by HCV positivity of the donor. And this was even before the era of direct antiviral agents, which we have now. As for hepatitis C negative recipients, the SRTR data also showed similar survivals at 2 years, regardless of HCV positivity of the donor. And there were also, and this is a quote from the study as well, there were no de novo or recurrent hepatitis in the donor NAT positive to recipient negative group. There are several other recent studies, albeit smaller in size, that showed 100% SVR post-transplant therapy with direct antiviral agents. This shows that we have alternative for patients who otherwise could be facing death if not transplanted. Now, in summary, even Al Capone understood the concept of supply and demand, and what he supplied was not nearly as precious as livers. So to summarize, we have this untapped pool in HCV livers. We have effective therapies with good safety profile, with hundreds of organs being discarded on annual basis, which means hundreds of lives being lost on annual basis. That being said, we can and we should bridge the gap between supply and demand. Let's save livers and let's save lives. Thank you.
Thank you very much. And for that really it's all yours, Dr. Stonecipher.
Thank you. Thank you. I had a little trouble with my audio there. Thank you for allowing us to participate in this debate. And the University of Maryland would like to argue against the routine use of hepatitis C positive donor organs in hepatitis C negative recipients. Although DAA therapy for hepatitis C shows promise for the treatment of donor-derived infection, it's premature to consider the use of hepatitis C viremic organs as routine based on the assumption that cure is guaranteed. It's true that momentum has been building in this direction, but before we get carried away, we have to make certain that all potential risks are identified, both in order to mitigate them, but also to make sure that transplant recipients can make a fully informed decision before consenting to receive a hepatitis C positive organ. Therefore, we recommend that the organ transplants involving hepatitis C viremic donors be performed under IRB approval in keeping with the 2017 consensus statement from the American Society for Transplantation. So intentional iatrogenic infection with hepatitis C is not without risk. In some scenarios, the use of hepatitis C infected organs are associated with worse outcomes. For example, a study of hepatitis C negative heart transplant recipients from the Cleveland Clinic compared outcomes between those who had received a viremic donor versus those that received a negative donor. Donor positivity was associated with a 2.8-fold greater risk of mortality and 3-fold greater risk of vasculopathy. Another study showed the recipients of hepatitis C viremic donor hearts who themselves developed viremia after transplantation had higher rates and greater severity of acute cellular rejection, even when DAA therapy was initiated as soon as 7 days after transplantation. In kidney transplant, the kidney donor risk index was developed to estimate the risk of graft failure relative to that of a healthy 40-year-old donor. Hepatitis C positivity was associated with a hazard ratio of 1.27 for allograft failure. Fibrosing cholestatic hepatitis is a rare but severe complication of hepatitis C after transplantation. There are little data available regarding the use of DAAs for FCH after transplantation. What is available has been published in case reports. Although FCH is generally not considered an early complication after transplant, several case reports describe early onset of severe hepatitis, one as early as 14 days after liver transplant for acute liver failure, and 2 in the setting of hepatitis C HIV co-infection. Of note, both co-infected patients relapsed after their first course of hepatitis C treatment, highlighting that SVR is not universal. The use of viremic organs can result in a downstream bystander effect. For example, non-liver organ transplant recipients may be at risk for undiagnosed liver disease. As an example, a patient with diabetic nephropathy may have significant but unrecognized hepatic steatosis. Giving this patient a hepatitis C viremic organ would put him or her at risk for accelerated fibrosis or even cirrhosis in the future, potentially requiring another transplant. Additionally, we know that hepatitis C does not affect the liver in isolation. Transplanting a hepatitis C viremic organ into a NAT-negative recipient risks the development of extrahepatic manifestations. For example, a heart transplant candidate with already tenuous renal function could receive an organ from a hepatitis C viremic donor. In this patient, the development of glomerulonephritis would be a serious complication. The volume of literature regarding the use of hepatitis C viremic organs in NAT-negative recipients is rapidly expanding, but unfortunately, the majority of these published studies are limited by a small number. The Thinker and Expander trials frequently cited studies looking at DAA treatment of donor-derived hepatitis C infection after renal transplantation. Each had only 10 participants. A more recent study from Stanford looked at NAT-negative recipients of viremic donors. Although outcomes were favorable, the sample size was again 10. This raises the question of generalizability to a larger and potentially heterogeneous transplant population. These studies are also limited by short-term follow-up. The majority of them have been published only since 2017, with the long-term implications of even transient viremia unclear. And even in the pre-transplant population, we know that the rate of SVR is not 100%. Studies on the use of hep C viremic organs in transplantation have described treatment failure. Amongst transplant candidates, the stakes of failed treatment or relapse are much higher. Each delay represents potential for developing complications from hepatitis C. A study from Penn looked at the general DAA accessibility. In a matched comparison, patients with commercial coverage were 6.5 times as likely to start therapy when compared to patients with Medicaid. Despite high SVR rates in clinical practice, there are still barriers to care. A study from Mass General noted significant logistical barriers impeding early access to DAA therapy after liver transplantation with a hepatitis C positive organ. Again, they had good outcomes, but they were able to obtain approval for DAA therapy in all patients only with the efforts of a dedicated team whose sole purpose was to get treatment covered. The authors noted that a similar degree of time and resource expenditure might not be feasible in general practice. Even when the coverage was granted, the approval process at times caused delays in treatment, risking the development of side effects for hepatitis C. Time to approval ranged from 24 hours to 10 days. Even more concerning was the increase in payer denials requiring documentation of chronicity or 6 months of viremia as a prerequisite to drug approval. In the immunosuppressed post-transplant setting, the likelihood of spontaneous clearance is very small. And as mentioned before, the risk of waiting is high. Drug interactions between protease inhibitors and cyclosporin are well known and represent a potential roadblock to treatment. Lastly, speaking to the points made by our opponents, the overall impact of hepatitis C viremic organs is likely to be low. In 2019, 8,372 liver transplants were performed involving deceased donors. The 2017 ASD consensus statement estimated that using hepatitis C positive organs would result in approximately 300 to 500 additional donors per year. Any potential benefit will likely be diluted over time as more programs adopt the practice. Therefore, it's unlikely that the use of hepatitis C viremic organs would go very far towards solving the organ shortage problem. In summary, the use of hepatitis C viremic organs in NAP-negative recipients is promising, and with larger, well-designed studies may well become standard of practice. At present, however, the literature is limited by small size and short-term follow-up. The risks of intentionally infecting organ transplant recipients with hepatitis C are not fully elucidated, and assuming that treatment with DAAs will negate them is oversimplistic. Organ transplant candidates considering a hepatitis C viremic organ must be well informed of these risks, and until they are better understood, we should argue against the routine use of hepatitis C positive organs in hepatitis C negative recipients.
Thank you very much, Dr. Stonecipher. And at this time, we'll have the pro rebuttal with Dr. Baba. Thank you.
Thank you, Dr. Jensen, and thank you to the American Liver Foundation for hosting the debate. I want to start off by a quote by Thomas Starzl, who we all know as the pioneer of liver transplant. In an interview late in his life, he recalled asking himself, what's out there that needs development but looks impossible? His answer was transplanting organs. I don't have to tell this audience how important it is to do liver transplants and the glaring discrepancy in the number of transplants being done, but the exceedingly high number of patients on wait list. Transplanting hepatitis C positive organs in negative recipients provides us with a unique opportunity to increase our donor pool. As we have shown you today, hep C negative recipients have just as good outcomes as any other patient, regardless of hepatitis C status of the donor. Our opponents will tell you that there are certain risks and uncertainties involved with this approach. There is concern for having fibrosis in the graft and potential for worse outcomes after the transplant. However, the data does not show that. Furthermore, all centers, including at our institution, we have a protocol where grafts with significant fibrosis are not used. There may be concern for negative outcomes with having hepatitis C post-transplant, such as fibrosing cholestatic hepatitis or metabolic syndrome that's associated with hepatitis C. However, these risks are small, and they can be mitigated by the use of DAAs. DAAs have now provided us a way to safely use hep C positive grafts in negative recipients. We have over a decade of data regarding the safety of DAAs. Furthermore, eradicating hepatitis C potentially eliminates any metabolic syndrome risk factors that may be associated with it. And the risk for developing fibrosing cholestatic hepatitis is actually fairly low in the post-transplant setting. Most of the data about low survival with FCH is up from the pre-DAA era. However, even if it does happen, we are ready because of DAAs and how effective they are. Thus, any concern regarding hepatitis C related fibrosis or metabolic syndrome is trivial. Access to DAAs has also improved in the last several years. The same is true in the post-transplant setting. Most studies evaluating outcomes of post-transplant hepatitis C from graft have actually shown that the median time to start DAA therapy is only 1 to 2 months after surgery. Most insurance companies have relaxed restrictions. From our own experience, there has been minimal hesitance from payers to start DAA therapy. And in fact, a lot of patients actually get started in a mere days after transplant before they even are discharged after their surgery. There may be some concern about DAA therapy and drug interactions in the post-transplant setting. However, these concerns are of minimal importance for two reasons. First, we have 2 approved regimens, and one of them does not include protease inhibitors. Secondly, even if we have to use protease inhibitors, the interactions with immunosuppressants, mainly calcineurin inhibitors, are minimal, and these usually can be managed with mild dose adjustments. Furthermore, all these medications can be used in any degree of renal failure, including dialysis patients. Some people may also raise the question regarding cost of DAA therapy. However, we would argue that it's actually more cost-effective to use hepatitis C positive graft in negative recipients and treat them with DAA post-transplant. Using this approach will likely help patients who have increased wait time and potentially even increased mortality risk. A recent modeling study also estimated that using any liver regardless of hep C status resulted in increase in life expectancy. This is probably particularly true in regions with high median melt to transplant, such as right here in the DMV area. In summary, we believe using hepatitis C positive organs should be a standard practice in clinical care. We are generally okay giving patients grafts that are CMV, hepatitis B core, or even in some cases, HIV positive. And there are actually no cures for those infections. So why are we hesitant to use a hepatitis C infected graft when we actually do have a cure for it? We are underutilizing organs that can save hundreds of lives each year. Restricting the practice of transplanting hepatitis C positive organs in negative recipients to only select centers will likely result in unnecessary deaths. We have an opportunity to improve care and reduce mortality while minimizing harm. And that's an argument that cannot be debated. Thank you.
Thank you, Dr. Baba. For the rebuttal of the con side, Dr. Asif.
Thank you, Dr. Jensen, and thank you to the American Liver Foundation. Our team's position is to argue against the routine use of hepatitis C positive organs in hepatitis C negative recipients. And our opponents will tell you that hepatitis C treatment is becoming more available and effective in the past decade, but there still remain significant concerns with the routine use of these organs. Our opponents tout the increased pool of available organs as a panacea to the insufficient supply of organs. But as healthcare providers, our priority first and foremost is to our patients. So what do our patients think? And though there are a general paucity of data about this topic, there was a study in 2018 done by Corey et al., which examined hepatitis C transplant candidate attitudes towards receiving hepatitis C positive organs. These enrolled patients were listed for solid organ transplantation, including liver, kidney, lung, and heart at a tertiary care center. Most of these patients had prior knowledge of hepatitis C, but only 60% knew that it was curable. And when asked if they'd be willing to accept a hepatitis C positive organ after being told it was curable, over 50% were unsure or unwilling. Worries cited included hepatitis C incurability, insurance coverage, fears over the organ not working, and post-transplant death. These were expressed in both the willing and unsure/unwilling patients. And as such, we clearly have much more work to do in patient education. Our opponents also argue about affordability of direct-acting antivirals as proof of treatment accessibility. As we all know, health insurance remains a divisive issue in our country, and in the details of our patients' healthcare coverage for hepatitis C treatment remain germane to this discussion. We know that while liver disease does not affect only one segment of the population, there is a disproportionate burden of disease on minorities and people of color. And to reiterate Dr. Stonecipher's excellent summary, there continue to be concerns that obtaining approval for DAAs may impede the expanded use of HCV viremic organs. These medications have been normally approved for use in chronic hepatitis C infections, but may be restricted in some patients with advanced hepatic fibrosis. Additionally, in some states, Medicaid programs have had a much higher rate of denying applications for hepatitis C treatment among chronically infected patients compared with other payers. Finally, I would be remiss to not mention the ethical considerations when using hepatitis C positive organs. Medicine is an art and not an exact science. And as physicians, we know that one of the principal precepts of bioethics is non-maleficence. Or in other words, first, do no harm. The goal of modern medicine is to strike a balance between the potential benefits of a treatment compared to the risks of harm. In that vein, the ethos of intentionally giving a patient an infection that they did not have before, a virus that can affect different parts of their body, and hoping that you can treat it successfully, is morally ambiguous at best and borders on hubris. In summary, adverse outcomes are associated with hepatitis C positive organs, including vasculopathy, fibrosing cholestatic hepatitis, the bystander effect, and additional effects. In addition, the studies to date have been small in number with a need for more research. Anecdotal data is great, but you can save someone's life with it. To that end, it is obvious that there are knowledge gaps in our understanding about hepatitis C positive organs and hepatitis C negative recipients. There is an urgent need for funding to support well-designed, IRB-approved research trials to prove the long-term safety of these organs in uninfected recipients, to determine the optimal timing of when to treat these patients, and improve the healthcare systemic logistics associated with the recovery and allocation of these organs. Thank you.
Thank you, Dr. Asif. So it's now time for questions. And I'll start with a question from our audience first before I get to our judges. For Dr. Stonecipher, understandably, there are risks to transplanting hepatitis C positive grafts in HCV negative patients. But if dozens of patients on the donor list die each day waiting for a graft, are the risks still worth taking if the patient consents?
I mean, that's a good point. And what we're saying is we argue against the routine use, right? And we feel that before we can tell a patient that it's 100% safe to accept this organ, we need more data. We just really need more data. And I would point back to the slide where I pointed out that the AST estimated in 2017 that only 300 to 500 additional livers or donors would be available per year, which represents only a small fraction of potential organs. And also that's assuming that all of those livers would be acceptable for use.
Does Dr. Baba have numbers or references to back up the small risk and improved outcomes with DAA therapy in comparison to old outcomes data without DAA therapy? Is there data?
I think the studies that have been published about the NAT positive to negative recipients, as far as when we reviewed the literature, we did not see any significant adverse outcomes. Yeah, there are associated side effects, but there were no reported cases of FCH. There were no reported cases of mortality or even graft failure with the therapy post-transplant. So, and I understand the idea of that. Yeah, there are the numbers of the studies. Patient sample size is low, but we all know that there's not going to be a randomized controlled trial about this. So a lot of the data about this and a lot of this has to be done from what the centers are doing based on the study trial design at this point. So we feel that these are safe and there have been no reported significant adverse events.
And this will be a question to Dr. Asif from myself. Are the horses already out of the barn? I mean, so many places are already doing this. It's making an impact. How do you backtrack? How do you go back?
That is a great question. I think it sort of goes to our central thesis, which is not so much that we are against hepatitis C positive organs being transplanted, but more so of a national system and infrastructures to standardize that care across the country, so our patients are not disadvantaged by whatever geographic region they're in necessarily.
Dr. Argo, one of our judges, do you have questions?
Yes, I had a question for the con team. If they are not in favor of using hepatitis C positive organs routinely, what would their strategy be for using these organs?
Well, would you like me to take this? Okay, so again, we just need more data and better design studies that have longer term follow-up, more patients. Again, ethically, it's difficult to design studies for this, but it's also difficult to look at a patient and tell them we know all of the risks and we can guarantee them cure with a DAA at present.
And Dr. Ananea, do you have a question?
Yeah, thank you. I have a question for any of the panelists. What is the graft survival rate? All of you talk about the morbidity and mortality associated with transplanting positive donors, but what about the graft survival? I guess Dr. Stonecipher's team should probably take that question because they're waging the debate that it should not be conducted. So do we have any data about 5-year survival grafts and 1-year survival? Any data? Because I didn't hear about that when I was listening to the presentations. Thanks.
I would argue that we do not, because we really have been seeing published studies on this since 2017. In terms of 1-year survival, I didn't see that specifically, but certainly we don't have long-term graft survival data.
Dr. Baba or Alpha, do you have any information about the 1-year survival or longer, since your team seems to have a lot of data on this project?
Yeah, thank you. The largest of the study that was published, which I believe was 2019, it showed 87 patients, but they looked at up to 1 year or maybe slightly more than 1 year, and the survival, there was no difference in terms of mortality when they compared to patients who did not get a hep C graft. It is true, yeah, we don't have 5-year survival data in particular about positive to negative patients, but partly that's because a lot of centers are hesitant to use it at this point. But we know from prior hep C positive to hep C positive patients that there's pretty good survival rates long-term.
We have a question also from the audience to Dr. El-Zair. You mentioned increasing the supply for men, women, and children. What data is available out there with regard to using hepatitis C positive donor organs in the pediatric population?
That's a good question. For pediatric, as we know, for pediatric population, the percentage of transplanted patients is way much less than adults, as the indications are different and the indications are not. It's not as common to transplant those patients. I don't think we have extensive data for the pediatric population. However, I'm going to go back. We're going to go back to the important point that we're trying to make, which is the supply and demand, and that there are those livers that are being lost, and the loss of these livers mean the loss of life. So when the alternative of transplanting a hep C liver patient is death, I mean, I think that's an easy choice for us to make.
All right, thank you. And I thank all 4 of you for really great presentations and rebuttals and answers to our questions. So at this time, I will now join the judges in a private breakout room while they review their notes and determine a winner for this debate. In the meantime, I would like to pass you back to my colleague, Dr. Rohit Satoskar, to tell you about what's new. Thank you.
Thank you, Dr. Jensen, and congratulations to all of our fellows so far. It's really been wonderful to watch all of these presentations. We really have quite a group of talented fellows, which is nice to see, because for us, this is going to be the next generation of hepatologists. While the judges deliberate, I'd like to thank our sponsors. So the ALF has put this program on, but it would really not be possible without our sponsors. So first, a big thank you to Trieste Patuch and Lee Ecker from our local sponsor, AbbVie. If we were in person, we would all give them a round of applause. Thanks to Carrie Silman from another local sponsor, Bayer. We are lucky to be joined by Denise Bentley and Ashley Thielen from our national expo sponsor, Mallinckrodt. Thank you, Denise and Ashley. Thank you to Mark Chasen, who is here representing our national bronze sponsor, CVS. And you may remember we have 2 national gold sponsors this year. So first, a big thanks to Jennifer Halliday, who's here on behalf of SI, and Peg Ridolfi, who is here representing Salix. So thank you, all of the sponsors. We could not do this without your support. Thank you again. I hope all of you are enjoying this program so far. As I mentioned sort of in my opening remarks, the academic debates are sort of very dear to my heart because I did participate in them once upon a time, and for the last several years have been able to see these events put on by the American Liver Foundation. And it's really a nice event because it not only showcases the talent we have in our trainees, as well as the strength of our mentors in working with our trainees, but it really allows us to get our institutions together, which is really an important thing, I think, to sort of share ideas in a fun, collegial way. And now during the pandemic, I think it's even more important, as many of us are, spending less time actually physically being with our colleagues. Most of our national meetings have also moved online and virtually. This really provides us a way to really communicate with each other and talk and learn. So again, thank you for joining us. I think this event so far has gone wonderfully, and thanks to the ALF staff for putting this together. Doesn't look like we've had, I'm going to knock on wood, we haven't really had any major technical difficulties, which is wonderful. As an ALF supporter, I can't let the night pass without encouraging you to donate. So this is a really difficult time for all of us. It's a difficult time for providers. It's a difficult time for institutions, but it's really a difficult time for our patients. And organizations like the American Liver Foundation are really there for our patients, to provide them support, to provide them education, and really no donation is too small. As you can see on our screen, our goal is to raise $5,000 tonight. If we can get above that, that would be wonderful. And all of this is really going to go to help our patients. So please click on the link to make a donation. You see it there on the screen. I believe it's also in the chat box, and your money will really be put to good use. All of those donations are 100% tax deductible also. So please open up your wallets. I see that that Dr. Jensen is back. So it must be that the judges have made their decision. And I'm going to turn it back over to Dr. Jensen to introduce our third and final debate. Dr. Jensen.
Thank you, Rohit. And even though it didn't take us long to reach a decision, it was a tight decision, which they all have been. Both of them have been very narrow decisions up to now. So our next debate, our third and final debate for this exciting night, is the pro side from the National Institutes of Health, is should patients with immune-tolerant hepatitis B be treated with antivirals? And they will argue the pro side, yes, they should. And the fellow presenters are Dr. David Yardeni and Dr. Julian Herkun. Their mentor is an old friend of mine, Dr. Theo Heller. Debating the con side, which is that patients with immune-tolerant hepatitis B should not be treated with antivirals. The fellows representing Johns Hopkins are Dr. Ayang Kim and Dr. Abdul Orsini. Their mentor is Dr. Tinsei Warida. As a reminder, each position presentation will be allotted 8 minutes, and each rebuttal allotted 5 minutes. And are the timekeepers ready? And if so, we're ready for the pro presentation by Dr. Yardeni from NIH. Thank you.
Dr. Yardeni, it actually looks like you're still muted. Wonderful.
Can you can hear me now, right? Okay, so first of all, I want to thank the American Liver Foundation for inviting us to participate in this important debate and for allowing us to answer this critical question. Should patients with immune-tolerant hepatitis B be treated with antivirals? And the answer that I am going to claim for you tonight is a definite, is a definite yes. And to explain my case, I want to present to you Beatrice. Beatrice is a 22-year-old female college student who, sorry, one second. Yeah, okay. So is a 22-year-old female college student whose mother is a known HBV patient. She's E antigen negative with under TDF treatment. And Beatrice has now been referred for a liver evaluation by her primary care physician because she received a surface antigen positive test. All right. And further evaluation reveals the non-significant past medical history. She's currently taking contraceptives. Her physical examination is completely normal. Looking at her labs, her transaminases are completely normal. Synthetic function is normal. Everything looks fine. Looking at her HBV profile, her surface antigen is obviously positive, E antigen positive, E antibody is negative, and looking at her delta profile, it is also negative. Viral load is off the charts with over 200 million international units. So you can easily claim that this patient is an immune-tolerant, so-called immune-tolerant patient. And considering imaging, liver ultrasound is completely normal, and a normal FibroScan is also presented. So what should the hepatologist do, in this case, Lloyd the liver, or any given hepatologist do with this information and Beatrice? So he should consult the American Association for the Study of Liver Disease, the European EASL, the Asian Apostle. So this figure is actually from the AASLD 2018 guidelines. And to summarize it, I'm just going to go through this: surface antigen positive, E antigen positive, normal ALT, HBV DNA, which in this case is way, way beyond 20,000 international units. What should we do? Well, do not treat, monitor. Okay, sounds great. So let's continue. So AASLD 2018, monitor. EASL 2017, monitor. 2015, Apostle, monitor. Sounds simple enough, right? So patient is advised to continue follow-up and monitor. And we tell her this, Lloyd the liver tells her this information, and any given hepatologist. And over the next 10 years, Beatrice graduates from college, she gets married, she gets a job, she has 3 kids, and life continues. And so does her high viral load. It always stays the same, and her HBV profile stays the same. What about imaging? Well, life. Sometimes she misses an appointment for ultrasound, sometimes she comes in. That's the way life goes, right? And then you get a phone call. So there's this gut-wrenching moment that any physician fears he might get this phone call, right? Which starts with, doctor, they just called me from my primary care physician clinic. They said I need to see you urgently. And this is the reason why. This is our ultrasound image of her liver with an hepatocellular carcinoma. Okay, so this is the gut-wrenching moment. So what happened? How did this happen? We're fine. We're acting by the guidelines. Well, this study from GUT from 2017, Kim et al. Shows that high risk of hepatocellular carcinoma and death in patients with immune-tolerant phase chronic HBV. I'll walk you through this. This is an interesting one. So there are thousands of HBV patients who are being followed up in this study. The interesting group here is this one, the immune-tolerant phase, much like our Beatrice, and the immune-active phase group. Now, if we look at table 1, we see that these groups are pretty similar in their basic profile. HBV DNA is obviously very, very high for both groups, but the immune-tolerant group obviously has normal ALT and AST, and that's normal liver function test, right? And immune-active group, whoa, that's 5 times the norm, right? The upper limit of norm. So this group is sick, they should get treatment. This group shouldn't get treatment, they are basically healthy, right? So let's see what happens. So if we look at this graph, then something went wrong. The sick group is fine, not fine, but definitely better than the healthy so-called group, which actually received much higher incidence rate of HCC, and also the annual rate of death and transplantation was also significantly higher in the immune-tolerant group. Let's go further. 2006, Chan, risk of hepatocellular carcinoma across the biological gradient of HBV level. What do we see here? High HBV DNA level, high incidence of HCC. Let's see, E antigen positive, okay, for almost 4 times the upper limit of 4 times the risk in comparing to the seronegative. Let's go further. Gastroenterology 2016, interesting study, HBV DNA integration and clonal hepatocyte expansion in HBV patients considered immune tolerant. Okay, considered immune tolerant, look at that. So we all know that if you look at the slides of biopsies of patients with immune tolerant disease, you wouldn't see anything interesting, right? There is no inflammation. But what happens at the cellular level? This parenchyma is going through some changes. There is ongoing proliferation of hepatocytes. And while proliferation is taking place, hepatocyte clones are being created. And if you can see, the immune tolerant clones are very similar to the E antigen positive immune active clones, which are not farly different from the HCC clones. So this actually creates a potential indeed for HCC to occur. So the authors of this study actually say that we should abandon immune tolerance and call this high replication, low inflammation phase, as it is not particularly innocent and something is definitely going on inside the parenchyma. And these findings further challenge the notion that this phase is devoid of disease progression and certainly raises questions about the timing of therapeutic intervention to minimize genetic damage to the hepatocyte population. So just to finish up, New England Journal of Medicine 2002, hepatitis B E antigen and the risk of hepatocellular carcinoma. I think this slide and this graph is self-explanatory. So the next time, and 1 second before that, just to summarize from the New England Journal of Medicine, persons considerably at high risk because of positivity of E antigen would be candidates for antiviral treatment and very close monitoring. So Beatrice is definitely not the exception in this one. And the question I raise to you is, what would you do the next time you meet a patient such as Beatrice? Thank you.
Thank you, Dr. Yardeni. And at this time, we'll hear the con presentation by Dr. Kim. Dr. Kim.
Thank you, everybody, for having us tonight. Dr. Rossini and I will be making the case that not everyone in immune tolerant phase should be treated. So here's our brief outline. We'll first talk about the immune tolerant phase and current guidelines to support and the current evidence to support the current guidelines. And we'll conclude by asking ourselves, are we ready to treat everybody at this point? So this is a diagram that we're very familiar with. We're going to be focusing on the immune tolerant phase, which is defined as the high hep B DNA level, E antigen positivity, surface antigen positivity, and normal ALT. Currently, as the other group had recommend or suggested, the current guidelines are not recommending treatment for everybody in immune tolerant phase. So if you look at this diagram from AASLD, in patients with surface antigen positivity, E antigen positivity, ALT less than or equal to upper limit of normal, which is defined as 33 for male and 25 for female, with a DNA level greater than 20,000, AASLD says to not treat. EASL is very, very similar. Oh. Did I not share my screen? I'm so sorry. All right. Can I share my screen now?
Yes, you're all set. Thank you so much, Dr.
All right, so I'm sorry about that. So EASL is very similar in the sense that we are talking about immune tolerant phase, but they have a different names for it, which is E antigen positive chronic hep B infection. And EASL says that, you know, these patients in this phase may be treated if they're older than 30 years, but this doesn't mean that everybody has to be treated in this phase. And currently, as the other group had argued, there is a changing concept on immune tolerance. So we used to think that there is a lack of immune-mediated response to hep B infection, hence the word tolerance, but recent studies are showing otherwise, that there's an ongoing immune activity. But the clinical significance to support universal treatment, however, is unknown. When we start somebody on treatment, we want to have several goals in mind, such as slow the progression of fibrosis and development of HCC, achieve hep E antigen seroconversion, and surface antigen loss. So how are we doing in terms of those goals? Well, for fibrosis, this is a study from Hong Kong group that included 57 patients in immune tolerant phase. Upper limit of normal for ALT was 53 for men and 31 for women. At the beginning of the study, the median fibrosis was F1, and these patients were followed for 5 years. At the end of the study, 48 patients remained in immune tolerant phase. Their ALT ranged from 4 to 22, and their follow-up liver biopsy showed a median fibrosis of 1. So this study showed that immune tolerant patients have minimal or low disease progression over 5 years. Another study, 453 patients with hep B E antigen positivity, the upper limit of normal for ALT in this study was 58. And if you look at the graph on the right side, most of the patients in insignificant fibrosis group had a ALT 0.5 times the upper limit of normal, or 29 or below. So as long as you have low ALT, which is considered normal, your risk of development of fibrosis is low. And how about HCC? So we know from the REVEAL study that the higher the persistent hep B viral load, the higher the risk of HCC, except for one group. So in group I, the viral load was greater than 10 to 7, but their risk of developing HCC was 5 compared to the other group. What's unique about this group is that most of them had E antigen seropositivity and normal ALT, meaning most of the patients in this group were in immune tolerant phase. And in terms of the other goals, E antigen seroconversion and surface antigen loss. So we've certainly tried treating these patients. So this study, the patients in immune tolerant phase were randomized to TDF or TDF plus Amtriva. And they were treated for 192 weeks. With the treatment, the DNA level went down very, very nicely. But at the end of the study, the E antigen seroconversion rate was super low, and nobody achieved surface antigen loss. And 20 patients from the prior study were followed for more than 200 weeks. Again, 3 patients achieved E antigen seroconversion, nobody achieved surface antigen loss, and 7 remained in immune tolerant phase despite 192 weeks of treatment. We've certainly tried entecavir and interferon as well. In this study, patients were treated for hep B with entecavir for 8 weeks, and then they received a combination treatment up to 48 weeks, and they were followed up until 96 weeks. Their primary endpoint was E antigen loss and DNA less than or equal to 1,000. At the end of the study, the surface antigen loss, nobody achieved that at the end of treatment or follow-up. Primary endpoint, only 1 person achieved that at the end of treatment, and no one achieved that at the end of follow-up. The DNA level certainly went down with the treatment, but rebounded very, very quickly. And more importantly, 50% of the patients reported adverse events to a total of 42 events. So entecavir plus interferon was not effective and could have been more harmful. So at this point, I think we have to ask ourselves, are we ready to treat everybody? Well, the fibrosis and HCC risk probably not as high as we used to believe. Medication side effects can be real, and they can also be harmful. There are significant expenses and finances associated with treating everybody. And which medication do we choose? As we've seen, we still don't have an effective treatment strategy, and we also don't know for how long we're supposed to be treating patients in immune tolerant phase. So we've gone over the hep B infection, the current guidelines, and the current evidence to support them, and also we've shared our reservations about universal treatment. So at this point, I would urge you to consider frequent monitoring rather than committing everybody to lifelong medications that may or may not be helpful. And I hope that we've convinced you that not everybody in immune tolerant phase needs to be treated. Thank you.
Thank you very much, Dr. Kim. And I may have neglected to say that your team is from Johns Hopkins and your mentor is Dr. Warida. For the con rebuttal, or for the pro rebuttal position, we have Dr. Julian Hercune from the NIH. Dr. Hercune.
Thank you very much. So first of all, I'd like to highlight a point that we had mentioned in our initial presentation, that treatment does improve outcomes in hepatitis B. And we're talking about hard outcomes. In a landmark study by Marcelin in Lancet in 2012, it was demonstrated that treatment with tenofovir leads to a regression of fibrosis and of cirrhosis at 5 years. And in that study, patients which were considered immune tolerant with an ALT less than 2 times the upper limit of normal were included. Multiple meta-analyses have backed up the assertion that treatment reduces the risk of HCC and hepatic decompensation. We would like to focus on these outcomes in terms of what should be the ultimate goal of treating patients with chronic hepatitis B. In response to one of the points that our opponents had mentioned regarding the cost of treatment, a study by Enriquez from the University of Penn in 2007 demonstrated that treatment is potentially cost-effective. In a model, lamivudine therapy was associated with a gain in life expectancy and a decrease in risk of HCC and cirrhosis, as opposed to no treatment strategy in immune-tolerant patients. And the cost of treatment was well under the threshold of $50,000 per quality adjusted life year gained. A lot of the data that we are presenting is based on more ancient studies. And encouragingly, the landscape of treatment options has evolved over time. Therefore, we should take under account the increased efficacy of the most recent treatments. Entecavir was approved by the FDA in 2004 and tenofovir in 2008. Both of these molecules virtually present no resistance. In addition, in response to the cost argument, tenofovir is now a generic. Therefore, this should alleviate that burden. And 2 additional points that we would like to make in terms of treatment options, which our opponents had mentioned, is the recent approval in 2012 of tenofovir alafenamide and current trials of potential new innovative antiviral therapies, which are underway. Tenofovir alafenamide was introduced recently, and one of the reasons why previous guidelines do not recommend treatment is the issue of safety. However, now with TAF, we have an option which could potentially alleviate that problematic. Its efficacy is non-inferior to tenofovir. There's no reported resistance. Treatment with TAF results in a significantly lower decline in bone mineral density and even an improvement in kidney function. In a switchover study by Lampertico published in 2020 in The Lancet, treatment with tenofovir actually resulted in sustained viral suppression and improved renal function and bone density after switching from original tenofovir. In addition, studies have demonstrated that the use of tenofovir alafenamide is safe in high-risk populations, such as HIV patients co-infected with co-infected HIV patients with chronic kidney disease and in pregnancy. And in response to the study that, in contrast to the study that our opponents presented, there are other encouraging studies with combination treatment with encouraging results. Notably one by Zhu published in Journal of Hepatology in 2010, evaluating interferon alpha and lamivudine in a cohort of immune-tolerant pediatric patients. And after 2 years on treatment, almost 33% patients achieved the E antigen circumversion endpoint, and almost 20% lost the S antigen endpoint. Furthermore, while these data are encouraging, we do want to point out the fact that the endpoint of losing S antigen is desired in all cases of hepatitis B virus infection. However, it is difficultly reachable, so we should not expect to have or expect that for immune-tolerant patients that we do treat. Furthermore, and in conclusion, there are situations in which treatment is already accepted in order to lower viral loads, and this is recognized by EASL and AASLD in pregnancy to prevent vertical transmission, in patients receiving chemotherapy, in chemoprevention in patients over 30 years old or 40 years old, and in healthcare workers. Therefore, as we already approve treating those subgroups, why should we withhold treatment from all immune-tolerant patients? Thank you.
Thank you very much. And at this time, for the rebuttal of the con position, Dr. Orsini from Johns Hopkins.
Hi, everyone. Thanks to the ALF for the opportunity to present our rebuttal against treating patients with immune-tolerant, i.e. IT, phase of HPV infection. While by definition, these patients in so-called immune-tolerant phase may have high viral load, they certainly have an intact immune system. They're clinically stable, biochemically normal, and histologically fairly intact. So the question is, why would you fix a system if it's not broken? There is consensus across virtually all the liver societies on not treating patients with, or not treating patients in the immune tolerant phase. By the way, I just want to put our opponents on notice here because they come from the NIH. And it should be worth noting that NIH has a consensus position on this. It says, do not treat these patients. The dramatic presentation of Beatrice is something I may not be able to answer directly to because I do not have the details between when she was diagnosed and when she developed what appeared to be HCC. Whether her follow-ups have been in place or whether she missed any of those, to what extent the close follow-up guided by the guidelines have been followed. So that's a different debate for us to have if time should allow. But why would you treat these patients with the characteristics I've mentioned earlier? There is certainly every reason for you to treat an HBV patient in order to mitigate against progressive liver disease, i.e. cirrhosis, HCC, or liver-related mortality. So did treating IT patients achieve any of these goals? The answer is no. In fact, there is no evidence to show that treating IT patients changes the natural history of the disease. And this is quite important. Proponents of treatment often will allude to the natural history reveal study as credible basis to treat these patients due to correlation of viremia with HCC risk. However, the study was not limited to patients with IT only. Only 15% of these patients actually belong to the E antigen positive group, and which means much less of those were actually true immunotolerant patients. And then the average age was 45. But besides that, there have been studies going back again to the same study revealed in 2011, published in Gastro by Chen et al. They've showed that going back to the same data, when you reclassify the patients and have the group with IT within the IT phase, there's been no increased risk of HCC. So additionally, we've shown evidence that even when you treat these patients, the immune tolerant or IT patients, the viral level should back up after cessation of treatment. So does it mean you have to be treating these patients otherwise asymptomatic indefinitely? What is your measure of success or efficacy of treatment? There are two acceptable treatment endpoints which our opponents haven't been able to elaborate. And that is E antigen seroconversion or S antigen loss. Do treating IT patients achieve any of these? The answer is no. And this is core to the debate that we're having tonight. There is no proven advantage by any of the measures mentioned above from treating IT patients as against leaving them alone. In fact, you leave them on their own, they're capable of seroconverting by themselves without the help of treatment in maybe more than 85% of the cases. And none of the drugs available have been able to show this rate of seroconversion, by the way. And again, there is data similarly for S antigen loss. So these are the benchmarks that you look for when you're treating as a gauge of viral control. If the outcome that we're looking for, that is prevention of cirrhosis and HCC, should be avoided. Again, at what cost are you going to treat this patient? Have you considered the physical and financial burden on the patients? We've shown how majority of these patients have come out with treatment emergent issues that have to be tackled. How about resistance? I'm happy that my colleague, my opponent mentioned about lamivudine. The majority of cases, the burden of disease of HPV is actually
Whoops, it looks like we lost the audio and visual, and we'll wait for him to.
No, Dr. Jensen, it actually looks like he went over his 5-minute mark, so we will now move on to the Q&A section. Looks like our timekeeper is feeling a little ruthless.
Oh. All right. Okay. Well, it's interesting to see that we have very vigorous timekeepers for this session. So let me. Those were stellar presentations by everybody, and let me start some of the questions before we get to our judges, Dr. Shetty and Dr. Thomas. So first, let me ask a question, Dr. Kim and Dr. Yardeni, sort of mixed in. So Dr. Kim, or Dr. Yardeni, did your patient Beatrice have a family history of liver cell cancer? And then Dr. Kim, whatever that answer is, does the presence of a family history influence your decision to use antivirals in these immunotolerant patients? So Dr. Yardeni, family history of HCC?
So I would say that this is obvious. Family history is obviously a risk factor. We all know that. This is obviously a risk factor. And I intentionally didn't put that factor in because Beatrice is the phantom menace. This is the patient that we're all going to miss. This is the patient that we're going to tell her it's going to be okay. Don't worry, you're in my care. I will take care of you. You are in the stage of disease that doesn't need treatment. And this is when things go wrong. This is when things deteriorate, because we know, guidelines aside, life has its complication. Life doesn't always allow us to monitor these patients as we should. And obviously, if there was a risk factor, this would have been a much easier case if there was a risk factor of previous family history of HCC. But Beatrice, she's highlighting the type of patients that we're going to say we're fine by the guidelines. This was my point.
And Dr. Kim?
Yeah, so I think that's a very good point that you're giving us, Dr. Jansen. So if there was a, family history, actually the EASL is recommending that if there's a, risk factor such as a family history of HCC, then they should be considered treatment. But again, that doesn't mean that everybody in immune-tolerant phase has family history of HCC, and that doesn't mean that everybody in immune-tolerant phase should be treated, which is what we're arguing for today.
Great, thank you. And for our judges, Dr. Shetty, do you have any questions?
Yes, I do actually. First of all, I'd like to commend the speakers. This was really a very excellent presentation. So we have our work cut out for us. And I just had a question for Dr. Yardeni. This is similar to what Dr. Jensen brought up. It seems fairly obvious that not all immune tolerant patients are the same, right? So there are varying degrees of risk in terms of progression to cirrhosis, in terms of HCC development. So what I wanted to ask Dr. Yardeni is how do you deal with this in real life? How do you stratify patients according to the risk, and does that affect how you offer treatment to them?
Well, obviously, risk factors, as I've stated earlier, risk factors are obviously a main issue here. I would definitely evaluate a patient for risk factors such as family history and country of origin or ethnicity, because these are well-known risk factors. And obviously, if risk factors accumulate, this will further increase my decision to treat these patients. If I were to decide not to treat a patient, I would have to really reinforce a very, very strong monitoring regimen on this patient. I mean, bring him in and monitor, because the data is scary. I mean, when you look at the papers that I cited in my presentation, obviously it's not the majority of cases. These are minor percentages, but still every one of those is a patient that was probably told that he's okay, doesn't need treatment, and we missed him. So if you're going to decide not to treat, you really need to educate the patient and get him to the office for very frequently. And if there are risk factors, such as you stated, obviously you just need to treat, because as my colleague, Dr. Herkoon stated, these medications are not as expensive as they once were, and the adverse events and their adverse effects are very, very limited, if at all.
Thank you very much. Let me ask Dr. Thomas if he has any questions.
Yes, thank you. Great job on both sides as well. A question for Dr. Orsini. We make the point that we may not see surface antigen or E antigen loss, but the patient's often still very anxious, being on the side of their on their end about how we're not doing anything about these high viral loads. And what would you suggest in addition to blood work we should be doing to follow up these patients?
Is Dr. Orsini still with us?
Or Dr. Kim could take the question as well.
I'm here.
Okay.
Here he is. Okay.
Thanks for the question. Yes, so certainly there are certain patients that fall within a higher risk region, in which case you may have to probably provide a more stringent follow-up. Certainly routine treatment of this patient is not recommended because, like I did mention earlier, there is nothing to show that treatment changes the course of the disease in the particular patients of immune tolerant. So in certain instances, for instance, if you have a patient with genotype C, for instance, you may want to maybe be a bit more aggressive because those are the patients that may have a more severe course and more likely to develop HCC. So these ones, you may want to keep them under wraps pretty early. And other patients with other risk factors like family history of cirrhosis of HCC, the guideline does make room for you to treat them, especially given the age cutoffs. For ASLD, it says 40. For EASL, is 30. APASL also 30, given certain factors that come into play. So yes, certain patients, like I did mention, may have to be under more rigorous follow-ups than the usual.
And so then if a patient needs that type of follow-up, would they then have to be followed by a hepatologist? Could you comment if a patient doesn't have access to a hepatologist, how could that be addressed potentially?
Yes, after some of these follow-ups, I think a primary physician should be able to do some of this follow-up to a satisfiable degree. The danger here is, when you try to treat, there's certainly the risk of, even though we're saying the resistance rates in entecavir and entecavir as well as TAF may be low, you wouldn't, for patients, the burden of disease, by the way, is in the developing world. So if you want to treat everyone in the developing world, what they rely mostly on is lamivudine, for instance. So if you use it indiscriminately in this patient, what you end up with is mutations in the HBV that may eventually cross-react with entecavir, in which case the patient may not even have the chance of using entecavir in the future. So, given the instance, if there's no hepatologist or if it requires more rigorous follow-up, certainly you may consider treating based on what the guidelines have given the age and all that is required.
Okay, thank you. And we have a couple of questions from the audience, and one is for the pro team, and I'll ask Dr. Hercune to answer this. Regarding the risk of HCC, what is the absolute risk reduction with treatment versus following screening guidelines? So what is the absolute risk reduction?
So that's a very good question. And just due to the magnitude of the number of patients who have immune tolerant hepatitis B and the length of follow which would be required in terms to objectify those events, I don't have a number available in terms of, and especially we don't have studies that randomize patients to one arm versus another in terms of that. So it would be difficult to give an accurate number needed to treat. We are basing all these affirmations on overall epidemiological data.
Okay, thank you. And another question for the audience for the con team, and maybe Dr. Kim, you can address this. Your data focused on the patients themselves, but how about the public health impact? Can you speculate on potential cost effectiveness to society with a universal treatment practice?
Yeah, so I think that's a very good question from the audience. Thank you for that. So we were actually talking about that point while we were preparing for the presentation. Most of the burden, as many of us had alluded to, of hepatitis B is currently not in the States, but in Asia and African countries where there's not enough potentially resources to treat these patients universally. And the cheapest drug that we have is lamivudine. And there's there's data to suggest that there is a high resistance developing for long-term use of lamivudine in hepatitis B. So in terms of going back to the question about the financial burden, I think initially it makes sense it probably sounds great to treat everybody upfront with the cheapest drug we have available. But currently the data suggests that there is high risk of, developing resistance to the medication that we have available, which could potentially add to costs later in the future. So I think, just looking at that alone, I don't think treating everybody universally makes sense at this point.
Thank you very much. And we still had other questions from the audience that we could spend more time on, but to keep us on our time schedule, I think we'll stop it here. Thank you all. You did a great job on this difficult and challenging question for all of us. And at this time, we're going to have an intermission, and the judges will go to their breakout room. Thank you.
Well, it's really been a spectacular night so far. Congratulations again to all of our fellows. You can now take a deep breath. You're done. All your hard work has paid off. The academic debates, really intend to challenge our fellows to think critically about policies and practices which really impact the community of liver patients. But it's more than that, because it's not only requires our trainees to think critically about these things, but it allows them to hone their debating skills and to develop coherent and concise arguments, sometimes arguing for a side which they may not actually personally agree with. So one of the things we didn't mention at the beginning of this was that the topics were chosen and then assigned randomly in terms of the pro and con. So you may find yourself having to argue something which you don't actually practice at your institution or you don't agree with. But everyone really did a spectacular job, and you can see that by the amount of questions that were generated and the amount of discussion that went on. And that's really what these debates try to do, is to inspire collegiality and collaboration, really with the hope of stimulating a greater passion and enthusiasm for the field of hepatology, something which all of us feel very, very strongly about. One last time, I would like to ask you to please consider donating to support the American Liver Foundation. It is the nation's leading liver nonprofit and provides a voice for millions of Americans who are living with liver disease. So any dollars that you donate tonight will be directed back into community education, patient programming, professional education, similar to really what you saw today. So you can click the link in the chat box or you see it up there on your screen also. This evening marked the second ever virtual academic debate. Prior to this, these debates were always done in person. And just recently, the first virtual one was done in New York, which was also a great success. So I hope you enjoyed this tonight, and please stay tuned for future academic debates. You can see on the screen there that the next debate will be the Utah-Arizona academic debates taking place on Thursday, October 29th at 6 p.m. You can go to alfevents.org to register for this. The link is also available in the chat box right now, I'm told. This year marks the 30th annual Irwin M. Arias Symposium. This prestigious symposium honors the work of Dr. Irwin Arias. For those of you who aren't familiar with his work, Dr. Arias spent his career as a clinician, basic scientist, educator, and mentor with the intent of bridging basic science with medicine. His studies focus on basic liver cell biology, clinical liver pathological conditions, and his lab is responsible for discovering the mechanisms of inheritable jaundice, that ABC transporters mediate bile transport, the AMPK and liver kinase B1 regulate hepatocyte polarization and bile transporters. This work established new paradigms for biliary secretion and molecular identification of inheritable liver diseases. These discoveries are important not only for our understanding of liver biology, but also have important implications and applications for the diagnosis and treatment of liver diseases. Dr. Arias has established a number of educational programs with the intent of bridging the ever-growing divide between research and clinical practice. Through the annual Irwin M. Arias Symposium, the American Liver Foundation honors his lifelong work of bridging basic science and liver disease. This symposium addresses critical aspects of the American Liver Foundation's mission through its focus on bridging the advances of basic science with better diagnosis, treatment, prevention of liver disease at the bedside. This is coming up on December 8th. You see on your screen there from 1 to 5 p.m. And you can also sign up for that at alfevents.org. I'd like to just finish up before handing it back over to Dr. Jensen. A big thank you to all of our evening sponsors. This could not be possible without you. Our two local sponsors, AbbVie and Bayer. And of course, we're very grateful to our national academic debate sponsors. The national expo sponsor is Mallinckrodt. The national bronze sponsor is CBS. And our two national gold sponsors are Salix and Asai. Looks like our judges are back. So this is the last you're going to hear from me. I'd like to thank everybody for joining us tonight, and a big thank you to the fellows. Congratulations to all of you. Each and every one of you really did a tremendous job. I think that pretty much all of the debates were probably close to a coin flip. Handing it back over to Dr. Jensen.
Thank you very much, Rohit, and you're right. It was almost a coin flip, and as the tie-breaking judge, you can blame me for the.
Come on, doctors. I'm still missing a few of you. Pop on.
Oops.
All right.
Am I on?
Kat, it actually sounds like you might be unmuted.
No. I got people on. Sorry.
Okay, and so tell me, what do I need to do?
You're good, Don. We can hear you.
Okay, good. On behalf of the judges, I have the pleasure of announcing the winners of this evening's debates. First, thank you to everyone who participated this evening. Each presenter was extremely well prepared. Determining the winner was not an easy process at all, and there was really good discussion amongst the judges of the pros and cons of each presentation. And it's truly been my honor to be involved in this evening's program. As a reminder, here is the criteria that was utilized to determine the winner. The position statement presentations were judged on their presentation skills, citing appropriate literature to support their case, summarization of the case, and audiovisual content of the case. The rebuttals were judged on presentation skills, effectively rebutting the opposition position, effectively supporting their own position, and how they handled the questions and answers. So on behalf of the judges, Dr. Satoskar and Dr. Warita, I again congratulate both teams from the first debate, Walter Reed and the University of Virginia, and the winner of the first debate is the University of Virginia. Thank you. On behalf of the judges, Drs. Argo and Dr. Ananaya, I want to again congratulate both teams from our second debate, MedStar Georgetown Hospital and University of Maryland. For the second debate, should hepatitis C positive donors routinely be considered for HCV negative transplant candidates, the winner is Georgetown. Thank you. And on behalf of Judges Shetty and Thomas, I want to again congratulate both teams from our final debate, the NIH and Johns Hopkins. And the third debate topic was, should patients with immune tolerant hepatitis B be treated with antivirals? And the winner of that debate was the NIH. So thank you to all 6 teams. Congratulations to the 3 winning teams. And that concludes my comments. And thank you to everyone for attending tonight. Congratulations to all who participated and to the winners. And thank you again to all the sponsors who are here with us tonight, always helping the ALF advance its mission with their support. Please stay safe. You are all important to our patients and our communities. And thank you all for all you do. Thank you very much.